I just want to say thank you very much to everybody for joining us again in our on the SAPA webinars. We're very fortunate to have Professor Heather Zar, who's going to be speaking to us about masks. She's done a lot of research into this. And then we're going to be having Dr. Anita Park, who's the medical manager at Red Cross Children's Hospital. I'm going to be dipping in a little bit and asking some questions about school attendance and some comments on that. And I think with that, we'll conclude an interesting webinar. So I'm going to start off by introducing Heather Zar, who is one of the chairs in pediatrics at Red Cross Children's Hospital. Heather, I just want to make sure that you can share your screen. And we're going to hand over to you. There will be time for questions and answers. You should be able to share.
Okay, great. Hi, everyone.
Everybody else quickly, and then Heather, if you can just unmute yourself, that'd be great. Okay. Just need to unmute yourself.
Okay, hi, can you hear me?
Yes, we can.
Okay, great. Afternoon, everyone, and thank you to Mignon for the chance to speak here today on this issue of masks, which I think is really a key issue both in healthcare and in public settings. Okay, let me just see. Okay, so I'm going to focus today, I'm going to speak a little bit about COVID transmission and then the role of masks in preventing transmission of viral infections generally and COVID specifically. And I'm going to then talk about universal mask usage in health facilities, the place of N95 and surgical masks and cloth masks in public. So just to briefly summarize, as you know, the model has been that COVID in fact is spread by droplet and contact spread. But in fact, what we know now is that there's a continuum of spread and that it's actually probably an artificial kind of separation, that in fact when someone speaks or when they shout loudly or when they cough, they emit a whole lot of droplets of various sizes. And that this then means that in fact transmission can occur by either of these three methods. And this is important because the data for aerosolized transmission of COVID is increasingly accumulating, and it also brings into question the 1 meter that is considered safe guideline, and I'm going to show you some of that just now. It's also not just an academic discussion because, of course, the way in which it's transmitted has direct bearing on how to prevent that transmission. So for contact or droplet spread, it's hand hygiene, gloves, distancing, and surgical or homemade masks. But for airborne transmission, N95 masks or respirators become much more important. And this publication in Science, I think came out yesterday. I can't remember if it was yesterday or today. You know that the literature is accumulating very, very fast, and it makes the case for this spectrum of transmission of SARS-CoV-2 including aerosolized transmission. And it suggests that masks are key in this and in preventing transmission. So what has changed in terms of what we know? Firstly, the old dogma of transmission occurs largely from droplets from symptomatic people is out. This gave way to the recommendations of a distance of 1 to 2 meters, hand hygiene, and wearing of masks only if you are symptomatic. And unbelievably, WHO has only changed their guidelines on the 5th of June about this. There is now a lot of evidence to show, firstly, as I've mentioned, there's aerosol spread. This is one study that showed viral RNA in the rooms of patients with COVID. Viral RNA found at distances up to 6 meters, highest concentrations in patients just on nasal cannula oxygen. These are not intubated or ventilated patients. Highest concentrations in the toilets and areas where personal protective equipment was donned in terms of healthcare worker risk. And this study concluded that aerosolization of virus was possible from normal breathing. And this, in fact, is what was presented by the bioaerospace, the National Academy of Sciences. Another, I think, good example showing why aerosol transmission, or that for the evidence of aerosol transmission. So this is the story of the choir in America that decided to go ahead with the rehearsal. There were 61 people, and no one was sick, really, although it appears now there may have been one person who was sick. They observed social distance. They didn't hug or kiss. But they didn't wear masks, obviously, because they were singing. Well, of those 61 people, 53 came down with COVID, of whom 3 were hospitalized, 2 died, clearly indicating the potential for a lot of transmission in this kind of situation, and the fact that what we now know, loud speaking, singing, those sorts of activities actually aerosolize virus and may be an important source of spread. What we also know now, and this is very controversial, you may have heard yesterday WHO said there's no transmission from asymptomatic people. Unfortunately, WHO has not had a good record in this epidemic, and this really ignores a lot of the evidence where we know or where there's strong evidence for transmission from asymptomatic or pre-symptomatic people, so people who in the prior 2 or 3 days before they become ill. And there's data from China, from Italy, from the Diamond Princess, from newborns in New York, where pregnant women giving birth were swabbed. All pregnant women, 15% were found to be infected, of whom 90% were asymptomatic. So there's a lot of asymptomatic infection. The CDC reckoned yesterday that up to 40% of infections may be asymptomatic, and there is evidence of transmission from asymptomatic or pre-symptomatic people. In fact, the estimates from China were up to almost close to 86% of infection of all new COVID infections were because of. And we also know that there are high viral loads prior to the onset of symptoms. This is the pre-symptomatic period where transmission may occur, and that there's prolonged shedding of virus. I'm not going to belabor this, but this just shows viral shedding in patients in Wuhan. And you can see that by 3 weeks, 66% of patients were still shedding virus. What we know about transmission, though, is dose exposure matters. So it's the amount of virus that someone is exposed to and the duration for which they're exposed to. And this, I think, is key in terms of healthcare worker protection, which I'm going to come back to. So what is the evidence that masks can prevent transmission of viruses? And very quickly, this is the evidence for other viruses, for SARS, for respiratory infections, generally for influenza-like illness. There is a number, almost 40 studies now that show that masks, and these are mainly surgical masks, have a significant protective effect for transmission of viral illnesses. This mathematical modeling study showed that if 80% of the population wore masks during the influenza season, influenza outbreaks would be eliminated. And we also know that masks are effective for reduction of MDR-TB, just surgical masks. And this is probably quite an underutilized preventive intervention in our context. How effective are surgical masks for COVID, though? And so this is a study of use of surgical masks in patients with COVID and in those with influenza. And the bottom line is that surgical masks reduced coronavirus both in aerosols and in respiratory droplets in both children and adults who were symptomatic from COVID. And in terms of influenza, the masks reduced influenza and respiratory droplets. And so the conclusion here was that surgical masks can prevent transmission of coronavirus and influenza virus in symptomatic people. And this is from the Science article that I alluded to that has recently come out. And it has a picture of how masks may reduce airborne transmission. If you see in the top picture here, the different particle sizes, and it comes back to what I was saying. We now believe that people emit a variety of particle sizes. Some are aerosolized, some are droplet. And without a mask, those particles are widely spread. And with a mask, in the lower picture there, you can see how exposure is really minimized. And this is for SARS-CoV-2 specifically. If one looks at the evidence for masks in containing COVID, looking to China or Hong Kong, you know that in China, masks were compulsory. There was a dramatic reduction in COVID infections associated with social distancing and masks. And in fact, after 5 million people left Wuhan before the Chinese New Year, there was remarkably little secondary community transmission. And where did that occur? Almost exclusively in families where masks were not worn within the family. Importantly, universal mask wearing also reduced other viral illnesses such as influenza or RSV. In Hong Kong, a very similar pattern. Most healthy people wore masks, very few secondary local transmissions. Those were only in households where the families didn't wear masks inside. And there was a precipitous drop in laboratory detection of influenza and other viruses. And this graph of the trajectory of different countries' COVID epidemics, I just want to point out, make a point about the countries in turquoise. Almost all of these countries have instituted lockdowns, social distancing, school closures, hand hygiene, and identification of infected people with self-isolation. But the difference between the countries in turquoise and the others is the countries in turquoise, largely from Southeast Asia, early initiated universal mask wearing. And some countries aren't even on the graph. For example, Taiwan is not on this graph because it has too few cases. It's now around 441 cases and a handful of deaths. What did Taiwan do? Taiwan did not even close schools or institute lockdowns. They instituted very good infection detection and isolation of infected people and universal wearing of surgical masks. They banned export of surgical masks and they made 10 million masks a day. Extraordinary example. Another example, Mongolia, right next door China, started mask wearing and the other public health strategies immediately in January when they had their first case. Well, they have less than 100 cases and almost no deaths. Let me go into the next. Lastly, a last example is the Czech Republic, and I'll come back to that when I show you another slide of how they also instituted universal mask wearing and the impact of that. But now I want to show you a really important publication that just came out in The Lancet, commissioned by the WHO, that looks at the impact of physical distancing, mask wearing, and eye protection to prevent against COVID. And this is a huge study, I think 171 studies across 6 continents, and it involves any study that looks at prevention of COVID, SARS, or MERS. And the points I want to make here are around these 3 interventions: physical distance of greater than 1 meter or more is highly effective for preventing or for reducing viral transmission, 82% reduction. But importantly, there is greater protection with greater physical distance. Face mask versus no face mask, 85% reduction. Sorry? Are you hearing me? Can I continue? Is that all right? Okay.
Keep going.
Thank you. Face masks overall, and this is a combined analysis of N95 surgical masks and cloth masks, resulted in 85% prevention of transmission. And eye protection was had a further effect in terms of reducing transmission. But let's look at the mask story a little bit closer. And on the top are the studies of N95 masks versus no mask, and lower down are surgical face masks. And what is the bottom line here? N95 masks were 96% effective for preventing transmission. Surgical masks were 67% protective for preventing transmission. This has got major impact for what we do in terms of our healthcare workers and what kind of masks we use. So the good news is N95s are highly protective. The good news is also that surgical masks, or sorry, these are surgical or cloth masks, are also protective. But in terms of environments where dose exposure is really mattering, healthcare workers at the coalface, N95s are going to offer much more protection. But we know there's a global shortage of surgical and N95 masks, and so cloth masks are now recommended in public settings. And I don't have enough time to go through this, but this just quickly shows you household materials' effectiveness against a spread of small micron particles. And you can see that usual household particles, cotton blend, t-shirt, or a dish towel, is really very effective. This is a single layer too. In terms of preventing spread of these droplets. A surgical mask up there offering here 90% protection. And so this is why cloth masks are really are now so widely used. And I just want to, let me see if I can show you this video. So this is a video of aerosolizing of particles when a person speaks without just nothing in front of them, and look at that, and you'll see the aerosol generated.
Now I'm recording. Stay healthy.
You see all those green droplets?
Stay healthy.
That's the aerosol produced.
Great. Less loud. Stay healthy.
Less aerosol when you speak less loudly. Good. Now, when you put a face cloth there, look at
recording. Yeah. Stay healthy. Louder. Stay healthy.
Absolutely
Louder.
No aerosol.
Stay healthy. Nothing.
And that's from the New England Journal of Medicine. Simple face cloth eliminates the aerosolization that occurs with loud speaking. And we know, fortunately, that our National Department of Health has moved to recommend widespread use in public of cloth masks. There are very good guidelines on how they should be used. They need to be washed, a single mask for each person too, and there are also some good videos on how to make these masks. I'm not going to. I said to you I was going to show you one more data about the Czech Republic, and this is a remarkable example. The Czech Republic has been instituted masks since the 18th of March, and you can see there, if you look around here, the 18th of March, over here, what has happened to their epidemic since then. As the Czech health minister has said, today we see this is one of the most important decisions we have made, and if it helped here, it can help anywhere. And what has evolved in the Czech Republic is this notion of it's socially important to wear a mask. Your mask protects me, my mask protects you, and it's it's turned around the stigma of wearing a mask, because whereas before it was quite stigmatizing to wear a mask, it meant you had an illness. Now, if you don't wear a mask, it actually means that you don't care about other people. So this is really a remarkable turnaround and change in the way masks have been perceived and the impact on their epidemic. The other advantages of universal masking, besides reducing stigma, are that they prevent people touching their faces. They serve as a barrier, especially in crowded places. We know that many people in South Africa cannot do social distancing. They need to come to work in taxis. They live in very crowded conditions. They don't even have access to adequate running water. So masks are really an important barrier in this situation. And they also create greater awareness of COVID and will reduce transmission of other viral illnesses, which in our context, I think is a real plus, given that we're in the RSV and influenza seasons and given our TB epidemics. But I do want to spend some minutes now addressing the issues of protecting healthcare workers and the use of surgical masks and N95 masks. And we know that healthcare workers are at risk. We are we are all aware of the increasing numbers of healthcare workers who are becoming infected around the country. In the USA, healthcare workers constituted around 20% of all positive infections where their profession was known, mostly female, as would be expected, in the median age of 42 years. Fortunately, most didn't get severe disease, but 10% were hospitalized and a proportion required ICU. And the impact on health services in terms of healthcare workers who need to be out of the service for at least 40 days is really a key issue. Similarly, in Spain, healthcare workers constituted around 12% of cases. In China and other areas, healthcare workers a sizable proportion of their epidemic. And I think what we have learned from these countries is that healthcare worker protection and the best protection we can offer our healthcare workers is key. So unfortunately, WHO has lagged with this. And while they have now recommended universal use of medical masks in health facilities for healthcare workers, and that means doctors, nurses, administrative staff, porters, everyone, they only recommend N95 for aerosolizing procedures. And also, unfortunately, aerosolizing procedures are very, very narrowly defined. So they're defined as CPR, as ventilation before intubation, intubation, non-invasive ventilation, or sampling respiratory samples or bronchoscopy. And these guidelines just came out. And unfortunately, I've showed you the evidence that in fact was commissioned by WHO, and they're not consistent with what we should be doing based on that evidence. What do our national guidelines say? And these two were recently revised on the 21st of May. And they say surgical masks for all clinical staff providing direct care to COVID patients, and surgical masks for all universal surgical masks. What is different in this revision is that in the prior guideline, there was no provision for surgical masks to be used for when you were caring for non-COVID patients. So in the prior revision, surgical masks were only used for if you were caring for COVID patients or patients with respiratory disease. In this revision, surgical masks are universally recommended, irrespective of what patients have. But the problem here is that N95 masks are only recommended, as you can see below there, but for clinical staff doing aerosolizing procedures, which again are the same definition used by WHO. And so, and this is a summary also from the national guidelines, universal surgical masks for clinical staff, cloth masks for visitors, and patients with COVID surgical masks, patients without COVID cloth masks. So the issue of what constitutes an aerosolizing procedure is an important issue here. I showed you data that patients on oxygen aerosolize the virus. I've shown you data that just speaking loudly can aerosolize the virus. And I've also shown you data that frontline staff, or at least that high exposure to the virus and prolonged exposure is a risk factor for transmission. And this is really pertinent to our frontline staff who are working in the ERs, in ICUs, in medical wards. So when this WHO publication came out in the Lancet, the one that shows the added protection of N95 over surgical masks, there's an accompanying editorial, which is really an excellent editorial. And I just want to highlight some of the key messages. It says that the 1 to 2 meter distance rule in most hospital guidelines is based on out-of-date findings. And there are studies now that show that droplets can travel as far as 8 meters. It also highlights that both the droplet and airborne transmission routes are likely to be at play, and they are a continuum for respiratory transmissible infections, particularly COVID. It highlights that no single intervention is completely protective, and I don't want to give the wrong message here. Of course, mask wearing must go hand in hand with social distancing, hand hygiene, environmental controls, isolation of infected people. But masks are an important additional intervention. And this editorial suggests, or strongly actually says that for healthcare workers on COVID wards or working in areas where there's a high suspicion of COVID, N95 or respirator mask should be the minimum standard of care. This study, and they're alluding to the WHO study, should prompt a review of all guidelines that recommend a medical mask for healthcare workers caring for COVID patients. So what do? We have limited stocks, particularly of N95 masks, and we also have limited stocks of surgical masks. I think we must limit public use of these. The public should be wearing cloth masks. They are effective and they can be easily made and used. We have to avoid stockpiles and private sellers. I believe that access and distribution should be regulated, possibly by our government. There have been philanthropic donations, and there are actually amazing organizations that have been created where people are donating funding for masks and for healthcare worker protection. We need to ramp up local production. If Taiwan can produce 10 million surgical masks a day, why can we not also look to local expertise and get our own industry going? And then there's the possibility of reuse or extended use of N95 masks. And as many of you know, CDC did issue new guidelines for possible extended use or reuse, recommending that gas sterilization, heat, or ultraviolet light could be used. There's also the model of using 4 N95 masks per healthcare worker. This is because the virus doesn't last longer than 72 hours. It's not viable for longer than 72 hours on any surface. So if you have 4 N95s and you rotate them each day, by the 4th day, you can come back to your original mask. Of course, you need to keep them in your own paper packet, and they're specific to the health worker. South African guidelines recommend that N95s can be used for up to 1 week for the same healthcare work. Those are largely based on guidelines for TB. And there is risk involved with use. But I think this data, this study is quite reassuring in terms of methods for sterilization and reuse. You can see here the 4 different methods for sterilization: ethanol, heat, ultraviolet light, or vaporized hydrogen peroxide. And you can see the decay of the virus is very quick compared to the control, so that the virus is diminished in most cases within an hour with any of these methods. Ethanol is not recommended though, because you lose mask integrity. But either of the other 3 methods are also okay. And I think in our climates, ultraviolet radiation is one to seriously consider. Of course, correct use and disposal of masks by healthcare workers is essential, because we really don't want them to become a vehicle of transmission. So I think if I can summarize with some key messages, masks must be part of a broad public health intervention that includes rigorous testing for COVID, rigorous contact testing, isolation of infected people, social distancing, and hand hygiene. We must have universal masks in healthcare facilities. At the minimum for healthcare workers, these must be surgical masks. I think for frontline health workers and for healthcare workers taking care of COVID patients, we do need to be using N95 masks. And universal use of masks by the public is also essential to prevent transmission in public spaces. This is a picture from the Czech Republic. Everyone is making masks there. They hang their masks outside. Anyone can take a mask. Here are some YouTube videos on how to make a good homemade mask. You should preferably have 3 layers. It should cover the face quite tightly. Should be made of a fabric that can be easily washed, that's non-porous. But you can look at these videos if you want, or the South African guidelines are also excellent in terms of how to make home masks. And I think our president sets a remarkable example for all of us. I think we as people in health facilities are challenged to do better for our healthcare workers and to advocate for wider use of surgical masks universally and N95 masks for our healthcare workers who may be most at risk. Thank you.
Thank you very much, Heather. That was really a great overview. We've got a couple of questions, but I think we're going to go to Anita Parbu's presentation next, and then we'll do questions at the end.